Hello and welcome to the Indian Health Service COVID-19 Clinical Readiness and Patient Care ECHO Tele-Education session. My name is Sean D'Andrea. I'm the Chief Clinical Consultant for Emergency Medicine for the Indian Health Service. And today we are going to start with a clinical update from the Chief Clinical Consultant for Infectious Disease for the IHS, Dr. John Irolu. And then we are very fortunate to be joined by two Southwest regional leaders in critical care. Who will be taking us through a conversation around both the immediate management of the COVID-19 patient, but also the long-term follow-up for these patients. So we have Doctors Michelle Harkins from the University of New Mexico, as well as Dr. Marilyn Glassberg from the Banner University of Arizona Health System. This will be followed by a Q&A, and then we'll close out. Please don't forget to submit questions on an ongoing basis during the presentation. Our speakers will attempt to provide answers on a rolling basis as we're having our discussion. And also, please don't forget to complete the post-session survey for CME credit. A couple of quick reminders. The session is recorded and your attendance serves as consent to be recorded. Following the presentation, a recording will be made available for distribution. And for access to the presenter's slides, please see the original ECHO invitation that was previously sent out. And again, as a reminder, CME is available for this session following the completion of the evaluation. And with that, it's my pleasure to turn over to Dr. John Irolu from Gallup Indian Medical Center, our Chief Clinical Consultant for ID. Thank you, Dr. Irolu.
Thank you. Great, thanks for the introduction. I'll be just covering some interesting things that have popped up in the literature the last couple of weeks. I have nothing to disclose. So first, some basic science, virology. Korber et al. Just put out a pre-proof article that's going to show up in Cell, hopefully looking again at this spike amino acid change at the 614 codon from aspartate to glycine. It's called the G-clade, and it originally made up about 10% of global SARS-CoV infections, but now it makes up in May at 78%. So this kind of became the dominant clade, first seen in Italy in February 20, so not present in Wuhan, but then showed up in Italy. It enhances spike flexibility, and what's fascinating about it is it leads to very high nasopharyngeal viral loads, and infectiousness appears to be enhanced, so there's more transmission, but apparently disease severity is not altered according to this group by Korber et al. Next slide, please. And then some fascinating human biology. This is a genome-wide association study of severe COVID with respiratory failure. So they evaluated 1,710 patients in Italy and Spain who had severe COVID and looked at 2,205 controls. And in these patients, they analyzed over 8 million single nucleotide polymorphisms. And they found one gene cluster that had 2 genetic susceptibility loci. So if you were positive for these 2 gene mutations, your odds ratio for getting severe COVID was 1.77. So a huge increase in severe COVID in the persons with this mutation, and then 1.32 for the second mutation there in yellow. And also in this paper, they looked at blood groups, and they found that if a person was blood group A, which is the dominant blood group in Western Europe, the odds ratio of severe COVID was 1.45, whereas the blood group O, which is dominant amongst American Indians and Alaska Natives, the odds ratio is down, it's low at 0.65. So blood group O does better than blood group A, kind of interesting stuff. So we're getting some really fascinating basic science biology tests both on the virus and on the human host that are quite fascinating in the literature the last couple weeks. Next slide, please. Great. So prone positioning, this is hard to do, but it's kind of an interesting result. It was studied in awake, non-intubated patients with COVID-19 and hypoxemic respiratory failure, published on the 17th of June by Thompson et al. In JAMA, Internal Medicine. So it's a real tiny study with only 29 patients with COVID who were admitted to the Columbia University step-down unit. And they did not include people who were mentally altered or who had severe distress. They simply asked the person on their own to lie on their stomach. So this wasn't the complicated proning that you have to do in an intensive care unit on an intubated patient, but somebody who was awake, alert, not intubated on a step-down unit, and asked people to lie on their stomach. They were able to get 25 of these 29 patients to do at least one session of proning lasting an hour. And they found that the oxygen requirement improved in all of them. The ones who were able to get an oxygen saturation greater than 95% had a risk of subsequent intubation of only 37%. So about a third had to be intubated, whereas those who did not achieve a SAT greater than 95 with an hour of proning had an intubation rate of 83%. So this was sort of like a stress test to see which way a person was going to go. I thought this was pretty fascinating data. Next slide, please. So remdesivir news. You're aware that Gilead originally donated lots and lots of courses of remdesivir across the country, 120,000 courses distributed through HHS to the states. And then you all know that we all have a bolus of free remdesivir from DHHS to the Indian Health Service. And the news over the last 2 weeks is that HHS secured 500,000, so 500,000 treatment courses of remdesivir through September from Gilead. So we apparently are getting 100% of their production in July and 90% in August and September. The wholesale acquisition price is $3,200 per treatment course on the market. But I checked with our headquarters, Indian Health Service Pharmacy and Therapeutics Committee, and we still have access to the free remdesivir through DHS, the original distribution. No immediate sign that that's going to be cut off. So the good news is Indian Health Service, we're okay with the original remdesivir bolus of drugs. Next slide, please. How about some more COVID treatment? In addition to antivirals, there are a couple biologics that have been studied. Mavrilimumab, which goes after GM-CSF, is a GM-CSF blocker. This was a single center prospective study by DeLuca et al., published in Lancet Rheumatology. They gave 13 patients the drug compared with 26 matched controls. Nobody in the mavrilimumab group died. 27% died in the control group, but the p-value was not significant. All the patients in the treatment group improved compared with only 65% of the controls. And the time to improvement was shorter by about 5 days in the group that got the drug. And there was less progression to mechanical ventilation. So this is kind of an interesting study, real tiny, and I'd love to hear what the follow-up studies show. And then tocilizumab for treatment of patients with severe COVID-19. This is from Wuhan. It's an older study published in the Lancet recently. And it basically used this T-cell receptor blocker. And they found that in their study, it decreased the duration of pressor support. I understand University of New Mexico is doing a similar study with a biologic plus remdesivir. And I'm really going to be fascinated to see what comes out of that study from UNM. So it's the biologic with remdesivir or remdesivir alone is my understanding. That's going to be an exciting study to have the combo. Next slide, please. We finally have full access to the Horvey et al. Paper of the effect of dexamethasone in hospitalized patients. Totally changed our practice here. So this is the recovery trial. It's a randomized controlled trial of 176 National Health Service sites in Great Britain, sponsored by the University of Oxford. So we talked about this briefly at a prior ECHO when we just had some brief reports by Dr. Fauci. So They had enrolled 2,104 patients and put them on remdesivir, with 4,321 allocated to just usual care, and their endpoint was death at 28 days. Death at 28 days was decreased with a risk ratio of 0.83. But if you look at people who required mechanical ventilation, the death was decreased by a third, with a risk ratio of 0.65, and death decreased by 20% in those who were just on supplemental oxygen. So based on this, approximately 2 weeks ago today, the Infectious Disease Society of America basically recommended dexamethasone for everybody who comes in the hospital and requires oxygen. So they use the definition of severe COVID disease being a SAT less than 94 on room air, which is very easy to achieve in New Mexico at our elevation. And they also recommended using it for anybody with oxygen. So we've started using dexamethasone on patients who are both in the intensive care unit and the floor. And we're using it in combination with remdesivir pretty much across the boards if the person does not have a contraindication like kidney disease or severe hepatitis. So we're hoping this is a game changer. It's too early to tell, but we'll see. Next slide, please. Some standard references that I always encourage you to use. And then lastly, close out with this picture. These are my cousins and niece standing on a rock over the place of emergence where the human race emerged in Konoma village. And it's a wet spot where a spring comes out where you can actually see where humans came out. I know this is contested, the place of emergence, but we think it's in our village, and this happens to be in my rice field, and it's called Temia Kelkuja. So I'll close there. Thank you.
Thank you, Dr. Iralu. Always appreciate that final slide. Ending on a positive note is thanks for doing that every week, and your effortless pronunciation of the biologic agents is to be commended as well, something for us all to shoot for. And thanks for bringing us up to date, as you always do. We're next joined by two leaders who are in the Southwest region. I did some quick math before we began our call today, and they represent collectively at a minimum of 234,000 square miles of catchment area. And that's only including the states in which their facilities are located. I'm sure they receive patients from other states. I know that in part because I send some of those patients across the border myself. Dr. Michelle Harkins is a returning presenter to this ECHO session. We are grateful for her taking time out of her increasingly busy schedule. Dr. Harkins is the Division Chief of Pulmonary and Critical Care and Sleep Medicine at the University of New Mexico. Thank you for joining us, Dr. Harkins. And Dr. Marilyn Glassberg is the Division Chief of Pulmonary Critical Care and Sleep Medicine and the Vice Chair for Diversity and Inclusion, as well as the Senior Director for Clinical Research for Strategy and Growth for the Department of Internal Medicine at the University of Arizona College of Medicine at Phoenix. Of course, I'm sure everybody's aware just how busy all providers are right now, especially the intensivists in the Phoenix area. So thank you both for presenting, and we look forward to hearing a discussion about both the immediate critical care of the COVID-19 patients, as well as what to expect down the road.
Okay.
Thanks for the invitation.
Thanks very much. I guess what I do now is just share my screen. Let's see. Can you see it?
Not yet.
How about now? Yes? Yes, great. All right.
Yep.
Okay, I'm just going to go back one slide. Michelle and I are really happy to be doing this today. We're going to share with you our experiences about managing these patients. First part of the talk will sort of give you some perspective on everything you sort of need to think about getting these patients to the facilities as soon as you can, and what the things you need to think about. And then we're going to tell you about some exciting endeavors in terms of long-term follow-up of the Native Americans, since both of our facilities have really been hit pretty hard by this. I want to start by a video though of successes. And so just like John ended with a note of success, I'm going to show you some of our successes.
Dr. Glassberg, there we go.
So we're going to start so those were all coming from very many areas within the Navajo Nation, a few from the Apache, and highlight some of the successes that we were able to achieve. And what you'll see in the end of the presentation is the follow-up of those patients who gave their permission to be in this video and wanted to share with you how much they appreciate what was done for them. I'll turn it over to Michelle now for the next few slides.
Thanks, Marilyn. So as all of you have seen, there are many clinical presentations of COVID-19, and we have had patients come in with heart failure or acute coronary syndrome. Many have had prothrombotic events and endothelial injury, and perhaps some of those were linked to very high D-dimer levels. Patients had either a stroke with CNS manifestations. We've had an encephalitis. We've had seizures, and probably 3 strokes as some patients presenting. In the prothrombotic events, patients had DVTs and PEs later on in their course. We've had worsening hypoxia 3 weeks after the original testing, and I'm sure some of these things are the things that you are seeing as well. And, you know, I'm mentioning the happy hypoxemia because as a pulmonologist, I usually like SATs to be good, better than 92, but now my theory is 88 is great. You know, if they look comfortable, 88 is great, and maybe we don't need to push the envelope because we've seen some other issues that we'll discuss later. We also have several young patients being admitted to the ICU recently, even from the beginning, but I would say now in New Mexico, the highest percentage, just like nationally, of spike in cases are the 20 to 30-year-olds. And we have 20-year-olds with no medical problems admitted to the regular floor, as well as those without very many problems admitted to the ICU as well. Some of the risk factors for the younger patients and risk factors for worsening disease are those that are obese and diabetic, and that may be in part from inflammatory mediators in the adipocytes, poor glycemic control, and other immune suppression that way, that those folks tend to have worsening outcomes if they are admitted to an ICU. Next slide. So many of you have heard there's maybe 2 pneumonia phenotypes. There's a question if that's really true. I think there's been the kind of the L phenotype and the H phenotype described in the papers by Gattinoni. in Italy, but more compliant type lungs. So when patients first came, we said just intubate them for transfer. Intubate early, because that's probably what you should do. We're rethinking that now, obviously, and the first few that came through our ICU got off the vent in 4 or 5 days, no problem. I thought this is not going to be so bad. But now we're seeing much more of the H, or the stiff lungs, the typical severe ARDS, and patients are on the ventilator for 2, 3, 4, 6 weeks, potentially. There are some patients that have very thick secretions, either on the floor in the ICUs, and so we are using guaifenesin. We use incentive spirometry prior to their intubation, CPT potentially on the vents and suctioning just to try to keep their airways clear, but we've had a few patients fail extubation because of copious secretions built up. If you have a patient in your hospital setting that has a new pressor requirement, that may suggest new sepsis, but I think it's more likely a myocarditis or the cytokine storm, or a new thrombotic event. Next slide. So how do you optimize the care of your hospitalized patient, no matter what your setting is? I usually suggest judicious fluids. I think a dry lung is a happy lung as a pulmonologist, and so you don't want to give too much fluid, especially as they're approaching respiratory failure and they're on a ventilator. But when they first come in, they're dehydrated potentially. So you want to give judicious fluid amount. And then if you do progress to where the patient is on the ventilator, and then we try to keep them, at least at UNM, in a even to slightly dry fluid balance to try to optimize their oxygenation. Again, the happy hypoxemic or 88 is great. We have patients on nasal cannula. We are keeping patients longer on high flow oxygen. We've had patients in the hospital for 15, 16 days on high flow oxygen alone. One of the things that can help protect you is we're having all of our patients wear a mask. So if they're on nasal cannula, high flow oxygen, wearing a mask over that as tolerated, I think is key to kind of help, especially if you don't have a lot of negative airflow rooms. And then progressing on to potentially BiPAP if needed, and or the ventilator. So I think we were thinking 30 liters, maybe didn't have as much of a aerosolization on our our high flow. And so we were limiting that to the floors, but we've now escalated to allow 30, 40 liters and to remain on the routine floor on 80% FiO2. So thinking outside the box and a little bit more leeway on our floor service as you have to develop places for these patients. Self-proning, as Dr. Irlu recommended or mentioned on the recent paper, we've been doing this on our floor patients and in the ICU, especially if they're, even nasal cannula or on high flow oxygen. And I think we've seen several at our ancillary institutions, Sandoval Regional Medical Center, where intubation, I think, was staved off because of a patient able to self-prone. We actually have people do it as much as possible, but 2 or 3 times a day for an hour at that time of proning as they can. We're using inhaled nitric oxide and prostacyclines if patients are escalating and they're on a ventilator. I know that's not available for a lot of the rural facilities, but that's a next step in our armamentarium when a person is on the vent. Incentive spirometer, again, I mentioned that before. We have that in our floor service or even in the ICU if they're on a high flow nasal cannula, just to try to help expand, open up their alveoli, improve their oxygen exchange, and then measures for the secretion management, like I mentioned. Next slide. So these were some of the data from the original proning back in 2015, looking at proning spontaneously breathing patients that were non-intubated that had ARDS. And it was a retrospective study, but if you really had patients start to self-prone, they may avoid intubation. And I think the paper Dr. Irlu just reviewed is exciting and proof of concept that it does work in COVID as well. Though it was a small population, I think that most patients or most patients could respond to this if they're able to do it, and it takes some coaxing. Next slide. So as many of you, you have the patient that comes in, and there's a spectrum of disease. So early on in the infection, they just may have mild constitutional symptoms. They may have a dry cough, diarrhea, headache, and low-grade fevers. And they may not present to medical attention until really they start to have more of the pulmonary phase. And the severity of disease goes up along with our black line here. And then at some point, the host inflammatory response takes over. And if we could really identify which patient stays in this stage 2, where they just have shortness of breath and hypoxia, abnormal chest imaging, and low to normal procalcitonin, and then gets better, versus the patient that has an exaggerated host inflammatory response that may then end up in this stage 3 where they develop ARDS, surge, shock, cardiac failure, etc. And they have a lot more elevation in their inflammatory markers. We have remdesivir, we have a variety of other agents that are being used, whether there are much data behind them or not at this time. And then steroids, of course, to add in when patients are hypoxic potentially, has shown some promise in the UK data. So if we could really identify which patient is really going to progress soon and be on the horn with each other a little earlier to think about transfer, that would be like the $1 million thing, right? And so we're following some inflammatory markers such as CRP, D-dimer, and as they tend to elevate in our patient population, it does tend to suggest they're going to have a worse outcome or progress and become sicker and require ICU care. Next slide. But I also have to say one thing near and dear to my heart and Dr. Earlow's heart. We work together. So don't forget about hantavirus. We've had 2 cases last month from Arizona. They typically start in May. So if you have a flu-like illness in the summer, we used to worry significantly about hantavirus, but now, of course, we've got COVID in contention. And these patients were tested several times for COVID, and they're like, well, they're really sick. It's got to be that. But then someone really looked at the labs a little closer. And management is really different for this patient population. For the patient with hantavirus, you don't give fluids, you give early pressors, and we really try to avoid intubation if we're able to. And you don't want to wait to try to stabilize this patient because they progress and they get really sick really quickly. And so you want to transfer to a center that has a ECMO potentially available before the patient deteriorates. Next slide. So the things that are different in hantavirus. So while COVID can have some thrombocytopenia, we're talking really low platelet counts, less than 150. Then they continue to drop down to 100, 80, 50, etc. They have immunoblasts, and an immunoblast is what is pictured on the screen here. It's a large lymphocyte, about 2 to 3 times the size of a regular lymphocyte with dark blue cytoplasm. That can be seen on the peripheral smear as patients enter into the cardiopulmonary phase. They'll have a left shift on their CBC and differential, and hemoconcentration is another key factor. They may have some other LFT abnormalities and a low albumin as well. Next slide. And this is the peripheral smear criteria for hantavirus diagnosis when you're entering the cardiopulmonary phase. So 4 out of 5 criteria are what are needed. And the 2 patients that came over from Arizona, they had thrombocytopenia and moderately, the female had about a 48, and then the next crit was 50, and then the next was 51 as they were testing for COVID. And so she really met all 4 criteria upon arrival. And thrombocytopenia, and then these immunoblasts. So if you have 4 out of 5, in an area that, assuming 5% prevalence, you probably have the disease. So I have to just throw a plug in for hantavirus because we still may be seeing that, and you really want to keep that in your mindset. Next slide. So when do you transfer? Well, earlier, and this is back to COVID now, earlier rather than later. And really, if you have a patient that's on a trajectory of rapidly escalating oxygen requirement over that day, that is someone that is reasonable to transfer if they need a higher level of care based on your bed situation at your institution. The method of oxygen delivery is really up to the transferring facility and the transport company's comfort. As I mentioned, we were telling everyone to intubate early for transfer. Well, we are not doing that now. Patients can come on high flow nasal cannula potentially, or really a non-rebreather with oxygen. They can come on BiPAP with a viral filter in place. And so any combination, but you really hope to avoid a crash intubation during flight. So whatever your transport company is comfortable with, and really the progression of the patient's oxygen requirement or escalation over the day probably could guide you on what to do before transferring. Next slide. And, you know, if the patient does require intubation, a central access is appreciated, but don't delay it to get it done. And it's not necessary, but I have been asked that by our partners through a variety of different IHS places. And if you can get it, great, if the patient requires intubation, but if not, I wouldn't hurry, hold up the transfer. Obviously, want any CT scans and lab values and family contacts. I found this to be an interesting thing. Sometimes coming from IHS, they have everything outlined beautifully, who the next of kin are, etc. But some of our other facilities are not as good as you are as getting that information to us. And so, you know, goals of care discussion, documented contacts, and then potential contacts if we needed to consider clinical trials. Next slide. I'll hand it back over to you, Dr. Glassberg.
So we divided this up so that how you get them, transfer them early. But now the question is, when you look at the sort of course of this virus, trying to understand what's going to happen for the survivors, right? And so we're trying to look at the people that have been through the ARDS phase, and can we see, since the course of those patients may fall into different, as we talked, the LNH type, how could we follow them? And so at U of A, we became very interested in creating long-term follow-up from the very first patient that was discharged. And what Sean asked me to review for you was sort of what did that workflow look like. So I'm just going to go through a couple of these tables and then show you how we've charted them and the visits that we've made out to the Navajo Nation to follow some of these people, so you can see what data we're trying to collect. So initially, obviously, the presentation is both in a COVID rule-out unit, which is in the sort of the lower old parts of the hospital, and then as well as the ICU patients. And we track all discharges. So those that are transferred out of the ICU and now go to one of 4 COVID rule-out but have now turned into COVID positive units, they're tracked from their initial presentation in the ICU, and those that haven't gone to the ICU that are still in the COVID positive area. As noted by Michelle and John, is that the starting, yes, is antibiotics, steroids, and anticoagulants. Very early on, we started an anticoagulation protocol actually on April 6th, where all patients received anticoagulation and steroids as part of our method of treating them, sort of our armamentarium. They were screened for what initially were expanded access trials and now are randomized double-blind trials. And the other thing that we did was we created multidisciplinary teams from the beginning so that we wouldn't have to make calls to bring in other services. So physical therapy, nutrition, case management, infectious disease, pulmonary, renal, all on the same phone call. And the 2 services that manage and continue to manage the COVID positive unit and the rule-out unit is pulmonary and ID together. And that's been incredibly effective for us in creating continuity of the management of these patients. They get a daily assessment, and there are workarounds made by Zoom on every patient. whether they're in the ICU or on the floor. This is now becoming a little more of a challenge with the numbers that I talked to you about before. Literally hundreds of patients. The rounds are much longer. We've divided that into teams, but every patient is separately rounded on and then documented, and I'll show you the flow sheets. When the patient is ready for discharge, all of that is planned out, and so they're given those that are either require oxygen or going to altitude. We've been able to obtain pulse oximeters for them. So they're all given pulse oximeters, and that's part of the e-medicine follow-up they receive as the documentation of their pulse ox. They all, for a lot of these patients, and which is an interesting topic, is really a very progressive, aggressive critical care weakness. I really haven't seen patients get this weak so quickly in my career. And so we've started a very aggressive management of physical therapy very early on in the ICU. The ones that are in the rule-out unit obviously are much more mobile, and that's not as much of a concern. At the time of discharge, what happens is that the internal medicine group, I'll show you, that we've created the COVID discharge receives every patient. A visit is set up for the next day after discharge and then 1 week afterwards, and then in serial visits. Those that still require oxygen, I'll show you, we haven't been able to manage all of them the same in terms of their anticoagulation. Initially, it was a very short protocol because we didn't know any better. And so some of them would get more progressively hypoxemic after only 3 weeks with a DOAC, but now they're on 3-month protocols and maintained on anticoagulation. So these are these spreadsheets that document everything they're on. They're on a central computer within the system. And sort of the management, if they've had an exacerbation, what that is. None of them have had to be readmitted to the hospital, but they have had recurrent hypoxemia. So that's the issue of the anticoagulation and understanding how long they will have to be managed. So these are some of the visits. So what happened when the early visits were being made is that we realized that a lot of the areas didn't have supplies. And I have to give Corey Detlefs credit for really helping us connect to the IHS, connect to the centers in Tuba City and Kayenta and White River. I don't think we could have done it without Corey and without a few very valuable Native American medical students who and other medical students as well, but they were networked and developed these outreach programs. And these are just some of the pictures from the trips they took to visit our discharged patients. And so the ones that you saw in the beginning of the video, some of them are in these photographs so that we could, they could see them hands-on. They've made a trip a month since this started. So April, May, and soon to come up in June. So the faculty that were involved in this, I list some of them. Harvey Hsu at the bottom is really to be credited with the follow-up and maintaining the follow-up. He has worked 7 days a week on this project and in conjunction with the physicians at the centers within the Navajo Nation. So this is one of the first patients discharged. And this is an expression she taught us. I wouldn't want to do damage to the Navajo, but for the English, if it must be, then it's up to me. And one of the medical students, one of the Navajo students said that this is really how they see what they've done, that this is their call to action. So I'll stop there and then we can open it up for questions. Thank you.
Thanks to you both for a terrific presentation that I think really fills some of the gaps of what we've talked about in the almost 3 months we've been doing these sessions. And I just wanted to quickly say, Dr. Glassberg, thank you for a very well-deserved acknowledgement of Corey Detlefs and his work, which before COVID was something that he's been a tireless partner and advocate for our medical teams in the Navajo area and beyond. So thank you for that. I'm going to start with a question, take a little moderator's privilege here and lead with first a comment and then a question. I was reminded, Dr. Glassberg, in your description of the multidisciplinary rounds that you have, and I think that's a very important point because many of the sites we work at, I'm at Fort Defiance, a 24-bed inpatient unit. We have an ICU. We have excellent hospitalists, but we don't have the ecosystem that is often present in where at UNM or at Banner. And I think it's important for us to remember, and I don't want to say anything that's going to lead to unnecessary transfers, but it is probably important for those of us on our side to remember it's not just can we manage hypoxia or not. It's can we offer the full package of care and input that these patients clearly need. And so just something I think for folks to consider who are on the call, that if you're in a site like ours at Fort Defiance, at a minimum, it's worth considering drawing in, I think, that input, even if you have to do it virtually. But it's more than just managing hypoxia.
Yeah, I would say that the multidisciplinary team, I think, saved us, and we've looked at it. It decreased length of stay, and most importantly, provided really assurance to the families and the follow-up, right? That we created the continuity within the system and then the continuity afterwards. And I've been really, I've actually been relieved by the multidisciplinary team, knowing that everybody was on the call to get the job done. And that there was some synthesis in the sense of how patients were managed. Whether we know that's the right way or the wrong way, obviously we don't. I think Michelle's slide that showed sort of this whole spectrum of what we're treating. And clearly, if we can understand what that early part looked like and stopped it, we'd be so far ahead. And we don't know, so we have this empiric management. The only other thing that I wanted to mention in terms of treatment of these patients that's changed really in the last week is the refractory hypoxemia, Michelle, that we're all seeing. That despite dexamethasone protocols changing, as John mentioned, and giving them, the anticoagulation, they appear to be refractory. And this week we actually did our first plasma exchange, entertaining the diagnosis, an old diagnosis of fibrinolysis shutdown syndrome, where the D-dimer continues to rise, the fibrinogen is high, the patient's adequately anticoagulated. For those facilities that have a TEG, they've looked at the TEG, they've looked at the anti-10A, they've looked at the anticoagulation, and nothing much else is happening, and the patient continues to be very, very hypoxemic. And I must say, it was rather successful. This patient's D-dimer was cut in half, the fibrinogen is cut in half, and she's on her way to coming off the vent. We are not the only center doing this. There are a few publications already out, and we may want to review them. But Emory has, I think, done 14 patients now, or 15. And we're starting to see these patients that I think that are in Michelle's last part of the slide, these refractory hypoxemic ARDS, that we don't know what they have. I would encourage everybody, this is an advantage, obviously, to transferring to a center, but these are also things we can think about as we see them, and we see them over time, this refractory hypoxemia.
And thank you for that. And it also, I think it speaks to the benefit of having the patient being under the care of teams that have seen now hundreds or thousands of these patients. While we, in our areas, we have often taken care of 100 or a couple hundred. Clearly, you're pulling together a tremendous body of anecdotal, at least, experience, which we hope will translate very soon into usable data, which it sounds like it is. I wanted to ask about the role of the arterial blood gas with regard to the, quote, happy hypoxemic. I am an emergency physician, was trained very, very loudly to that meticulous physical assessment of a patient should really guide a decision to intubate from the emergency department standpoint. You shouldn't be getting blood gases and making decisions based on that in the ED. Keeping an eye on the patient's mentation, their oxygen requirement, their SATs. I'm curious if the role of the arterial blood gas takes on a different meaning, given that these patients can exist stably hypoxic for some time. And would you recommend use of an ABG in ways that before COVID we wouldn't necessarily reach for immediately?
That's a good question. I think for us, you may be hypoxic, but your PaO2 may be okay. But you don't know until you actually get that value. I think for us, a PaO2 of 55, so I have 88 is great and 55 saves lives. So, so a PaO2 of 55 and above, I can handle. I like it a little higher, sure, but you know, that may be what we need to do. I think it will help you, obviously, if someone is retaining. You know, that may help you decide, well, maybe they need BiPAP. But I'd be interested to hear what you're doing in Arizona as well, Marilyn, about
Nope.
this. We don't follow it as closely.
Yeah, we don't. And I think we're using PF ratio. But it's truly remarkable how low these PF ratios can go.
Yeah.
I mean, these people really do tolerate, whether you want to call it silent hypoxemia or happy hypoxemia, they're perfectly fine at numbers we would all go, how can this be? And I think that accounts for tremendous amounts of dead space, the kind of disease they have, but we aren't relying so much on the blood gas. So PF ratio. PF ratio has been a lot of what we have sort of categorized the patients at, you know, with sort of alarms when it goes below 150, which is quite a lot of them.
Yeah. And I think just looking at, you know, the prior to intubation, you know, or what you do with the patient, it's how they say they feel. And then, you know, if their respiratory rate, just kind of trending that, and, you know, simple things that you know to do to accept, okay, well, their SAT's 88, but their respiratory rate's 22 or 23, and they feel okay. And, you know, hanging tight a little bit longer with that. It's been, you know, shifting to a new norm and thinking of ways to do things. And in the team approach, everybody having a different role on that team. You know, and it's teamwork, and I think you guys do a great job with all of your care, and we're learning, you know, how to help you, and then how to be comfortable with things not being perfectly euboxic. You know, their SAT's good and everything. It's just.
I think the other thing about these patients is often their BMIs are huge, and probably. I've come to accept that a lot of them have undiagnosed sleep apnea, OSA, and maybe some associated pulmonary hypertension, because some of the numbers are just unexplainable without that. And that's a daily conversation. I mean, we had one in the rounds this morning, a person with a BMI of 160 kilograms. So that BMI is off the charts, right? A lady with progressive hypoxemia and had just come in. So we didn't have the data on her, but, you know, peripheral swelling, things that would signal to you that she might have pulmonary hypertension, just undiagnosed because she's living somewhere out where she didn't, you know, she's been sitting in her chair, but somehow she comes in and now she has COVID. So that may be also accounting for some of the very low levels of oxygenation that we see.
And have you seen any evidence of increased prevalence of pulmonary hypertension in the recovering patients or recovered patients?
We haven't yet. So just like we haven't seen the chronic fibrosis or the chronic lung disease, what is being noted though is some low diffusion, some interstitial changes. For those of you that follow in Twitter, there are images that are being projected of very quick, what look like chronic interstitial changes happening over a very short period of time. You know, the old Hem and Rich. But we don't know what's going to happen. One of the reasons for this long-term follow-up, right, is to really answer your question. What are the sequelae that these people develop?
Well, we are going to eagerly be awaiting further updates from you and your team. It sounds like you've got an incredible program for tracking that data right now. Dr. Earlew's got a question or two. I wanted to give him a chance to ask.
Every time somebody from our hospital has a chance to talk to pulmonologists, we always ask the exact same question, and that is, what is the proper dose of anticoagulation, whether it be a heparinoid or DOAC? Is it prophylactic? Is it therapeutic? And Dr. Glassberg, I was fascinated to hear, are you sending everybody home on 90 days of anticoagulation? And what are you using again? You said something about a DOAC.
So here's what happens. If your BMI is too high, you can't get a DOAC. right? So your BMI is too high, you're going to get Lovenox. You're going to get Lovenox at dosages you've never seen before. I mean, I've never given anybody more than 100 twice a day of Lovenox, but routine here, right? So what happens is that we get them therapeutic based on the anti-10A and TEG. So we follow the R time. If the MA is prolonged, they're getting put on aspirin. So they're going on a baby aspirin now, which is a new part of the protocol, but they're not getting prophylax. So they're getting full anticoagulation. When they go on the DOAC, they're transitioned to the DOAC. They're followed by e-medicine. And obviously, you know, with the renal failure and things, these things all have to be considered. But when we only anticoagulated these people for 3 weeks, as I mentioned, we ran into trouble with progressive hypoxemia. So right now it's 90 days. And my prediction is that some of them are going to be on longer. We're trying to use their hypoxemia as the measure with the idea that certainly the autopsy studies and some of the radiology studies are suggesting really a severe vasculopathy, right, with these microemboli. So maybe that process continues on longer than we think it does, and thus they need longer anticoagulation. And this is why I think these patients must be followed.
Fascinating, thanks.
And
Dr. Harkins, are you using full dose now or the prophylactic?
We start with, you know, the higher prophylaxis, you know, the 0.5 BID of a low molecular weight per kilo. And then the patients that are on the vent a long time and are hypoxic, we're like, oh, what do we do? Do we do TPA drips low? Do we do regular? So it's been a split and hasn't been consistent. We are gathering a lot of other, platelet assays and other anticoagulation measures to put in a database to try to help sort that out. I think the higher risk patients we do send out on some long-term, you know, the bigger folks that we have had been treating with full anticoagulation, but it's not our routine practice. And that's what we're going to revisit within this next week or so as more data comes out. You know, we've had a couple of people that we had that had bleeds, of course, when you put them on full strength anticoagulation. So it's that risk benefit ratio. But I think, you know, having a setup like you guys in Arizona do, it's amazing with a true clinic that you're really following these patients long term, that you feel safe to do that, because some of ours just disappear into the Ethernet, and it makes you anxious to put someone on you know, anticoagulation for 3 months that isn't going to be followed.
The other thing I think that lots of centers have seen, John, is this. So some of them are just refractory to the heparin as well.
Mm-hmm.
So
Correct.
a lot of bivalve is being used.
Correct.
There's definitely, like, they don't behave like they should behave. I tell you, it's very odd. You know, I mean, all of us have been in the business using anticoagulation forever. These patients, and I don't know if a lot of it is related to BMI. I think a lot of it might be that, or viral load. And that, you know, you put that heparin or something on board as an anti-inflammatory as well, but it's not really working the way you think it's going to work. That's been my impression.
Thanks.
And this is a follow-up question timed very well, comes in through the Q&A. The question is, for those who are being kept inpatient, is it primarily enoxaparin or heparin itself that you're using to anticoagulate, or?
For us, it's a mix of both. I think
Okay.
Michelle will say the same thing. A lot of it is that we do better with heparin with the large BMI. And then when we fail with heparin, we go to bivalve.
Yeah,
And
we've
fail is that they don't meet the parameters, right? Because we measure, we're looking to measure that they're within, you know, a therapeutic R time, right? That they're anti-10A. So the anti-10A we keep towards the higher end rather than the prophylactic end, but we actually use those measures to take care of them. And we have looked at this data. I actually, we sent out a paper on the first 30 patients. We were told it was too few patients, basically. So this was very early on at the end of April. So now we have a lot more. So we're going to send out a much bigger paper. But just for interest, there's 23. The last time I looked at clinicaltrials.gov, 23 trials looking at anticoagulation.
Yeah, and I think we just don't know the answer and finding out the right thing. And we're using a lot of low molecular weight for prophylaxis. And we've had the patients that come in that have clotted, and that's their main thing. So arterial clots, and just chewing up the heparin, not working, going to bivalve, that's difficult. And then they still continue to extend their clot. And so it's frightening. It's really not sure, you know, it's not one thing for every patient. Unfortunately.
Yeah, so I think that's why we've done this move to this plasma exchange idea, and maybe think about, let's see, we're going to do 3 more today, so let's see what happens.
Yeah.
And so that's all fascinating, and it's reminding us, I think, how much more we have to learn. We know there's clots, the data out of Europe and then Detroit, anywhere from 23 to 30% of folks. We know it. Folks have PEs in very large numbers. So are you and should we be pursuing a diagnosis of PE, or should we just move right to the anticoagulation?
I get in our center that because these patients are COVID positive, they're not real excited about sending these people to radiology. And because some of that staff has become positive, I think if I recommended that, they'd probably fire me. But I think that by going to, based on what we know from autopsy studies, I feel comfortable giving them full anticoagulation once I've made sure they obviously don't have a risk factor. I think Michelle pointed that out really beautifully, that we have to make sure we're not giving somebody something that we're going to have them exsanguinate, or a bleed in their brain, or they've had, we make sure we go through it. And those patients don't get treated. So even though, John, I said 100%, it's 100% with qualifiers, right? It's making sure that we're doing it right. But in our center, Michelle, are you doing the same thing, I guess, is we're anticoagulating them?
Yes, and I think we also kind of go through and do the head to toe looking for DVT the simple way ourselves. Or, we have now convinced the vascular techs to come in and do that for us. That took a bit, but we would look for DVT first, of course, and that's very simple. But we will send occasionally a few people down. But if there isn't a contraindication, then we may just go ahead and presumptively start our heparin pending. It sorts itself out one way or the other, or we're able to actually get a scan done to verify.
Thank you. Yeah, I think that's, and also what Dr. Glassberg mentioned about this whole specter of closing CT down for an hour and a half with each hypoxic COVID patient that you might scan. I mean, so that's all of them, right, that you're admitting. So that's, I think, what a lot of centers are up against, big and small right now. So thanks for kind of sharing what your experiences have been around that. I do want to remind folks that there's a link in the chat that will get you to a session evaluation, and CME credit is attached to that. So please don't forget to have a click there. We've just got a couple minutes to go, and I wanted to ask you both on the back end of care. Thanks to Dr. Glassberg and her team, we're going to develop, I think, more and more knowledge around how to take care of these folks in the weeks, months, and years following their recovery. Now we're about 3 months into this or so. We are receiving patients back at our community health centers at this point. What would you share with those primary care folks? And Dr. Harkins, I think we talked about this a couple months ago. I posed the same question. I'm curious now, with a couple more months of experience, what you'd recommend to the teams that are going to be receiving the patients and taking care of them in an ongoing way, what to look for, what to keep in mind, and anything else you might add.
Well, I think, our patients now following them longer term, they're weak. They still need PT. They need to do something within the house, whether it's TheraBands or other things. They may be requiring oxygen, but I think they just need a lot of they've been through a big roller coaster, and they need a lot of emotional support, physical therapy type support, nutritional support because they've lost a lot of weight potentially. I think it's just being set up in your community to try to provide all of those things safely for the rest of the family, and as well as the patient coming back, and just preparing them that, they're going to be really weak. They may be confused. They may have other issues, that is going to take them quite some time to recover. And when you look at, ARDS survivors in general, the studies years ago suggested that, at 5 years out, they may not be, a significant portion of them may not be what they were before, doing their job, going back to work and having all of these things that they used to do. So I think we don't know what's going to happen in the future, but I think that, as Dr. Glassberg pointed out, they're incredibly weak and they may not be able to go back to work. They may not be able to do things for quite some time. And so I think, PT, physical support, emotional support, what they've been through.
Thank you. I remember that from last time, that it's most of us don't realize that this is a potential years-long recovery. And I think that's really important just to highlight and for everyone to be reminded of. Our primary care teams are probably going to be taking care of folks who are experiencing sequela of this for years, depending on how their ICU course went as they recover. Thank you for that. We are right at the hour, and I could go on and on. I just have to tell you, it's just a real privilege to, because these are the questions that come up every day in our clinics, right? And we would, kind of hang on and steal more of your time if we didn't know how busy you were. But we do. Very grateful for both of our speakers today. It's rare that we have two critical care leaders who collectively represent basically a whole quadrant of the country. So thank you both very much for your time, and your centers are both very busy right now. We wish you and your teams the best, and we hope all of them stay healthy and well through this. So thank you, Dr. Marilyn Glassberg from University of Arizona, Dr. Michelle Harkins, Chief of Pulmonary and Critical Care at UNM. Thank you both very much. To the ECHO team who keep this thing running very smoothly each session, thank you all very much. IHS headquarters for giving us time to have this, I think, critically important forum from time to time. Thank you to Dr. John Irlu, who keeps us up to date throughout the IHS and 638 systems around the country. Thank you for scouring the literature and bringing us the most salient findings. To all of your teams, stay well, stay healthy, and we look forward to seeing you again soon. Thank you all.